Excellent. So, everybody, Assalamu alaikum. Welcome all to our PHA session for this cardiac surgery topics. But this topic is very much relevant, but for our cardiology colleagues as well. And I wanted this topic to be more of an argumentative discussion rather than just a webinar. So I have invited all these cardiology colleagues of ours and the senior cardiologists to provide their opinion in the panel. Um, and I'm also very proud to announce that we have got the speaker who is the PHA Fellowship Awardee this year, Dr. Nasrin Akhrat. She's going to be presenting the topics for today. She is working for 8 weeks in UK under myself and Dr. Shakil Farid. So Nasrin, congratulations and thank you for accepting to present this paper. So I would just like to introduce my panel first. Let me just quickly go. I'll start with my cardiology colleagues because they are the invitee for us today. So we have got, first of all, we have got our very well-known Hafiz Vai. He's a trustee of PHA and professor of medicine and program director, cardiology fellowship program of University of Nevada, Las Vegas. Hafiz Vai, thank you very much for joining. I know how busy you are, but thank you very much. We have got Dr. Nasir Khan. He is also a trustee of our PHA and program director, cardiology fellowship program in cardiology section chief in Dallas, Texas. Nasir Bhai, thank you. I know you're on the road, but thank you very much for joining. And we have got Dr. Mashraf Ahmed, clinical assistant professor of University of Massachusetts. He's on call, but still joined. And last but not the least, our beloved Professor Dr. Abdul Wadur Chaudhry, sir, Director of National Institute of Cardiovascular Disease. Wadur Bhai, thank you very much for joining. I know how busy at the moment in Bangladesh are. From the surgical side, we have got Professor Dr. Jahangir Kobi, sir. Sir, he's outside country, so I don't think he told me he will try to join. And then we're supposed to have Professor Dr. Farooq Ahmed, sir, and Professor Dr. Nazmul Hussain, Director General, Health Bangladesh. I don't know whether Shuman has joined yet. I'll just remind you.
Bhai has joined.
Yeah. Okay. Thank you very much, Shuman. And we have got Dr. Prashanta Kumar Chanda, as usual, always Prashanta Da. Thank you very much for joining after all this busy work. And you can see Shakil Bhai has joined from air. So he's actually flying at the moment. So Shakil Bhai, thank you very much for joining. So Nasrin, I think you can start with your presentations, and then as we go along, we will ask our panelists to give their opinion and advice. And if anybody have any questions, please feel free to put it on the chat, and I'll try to bring it at the end of the presentation. Thank you.
Respected panelists and dear senior and junior colleagues, my name is Nasrin Akhtar. I'm presenting the 2025 guidelines on management of the aortic valve disease and real-world practice today. And today's session is moderated by Dr. Syed Asif Sadiq, consultant cardiac and aortic surgeon, Sheffield Teaching University. So before we dig down into our guideline, I would like to do a rapid poll about our current situation and current practice. Here is a male, 70 years old, diabetic, otherwise fit, and no other comorbidities, presented with breathlessness, NYHA class 3, diagnosed as aortic stenosis with mean gradient pressure of 33 millimeter of mercury. Aortic valve area is 0.8 centimeters, 0.8 centimeters square, and stroke volume index is 35 ml per square meter, LVA at 55. After testing with the dobutamine stress echo, his stroke volume index still remain 35 ml per square meter and mean gradient becomes 40 millimeter of mercury. So what would be the option of treatment for this patient? Option A, surgical AVR. Option B, active clinical surveillance. And option C, TAVI.
Just a quick poll if anyone wants to comment.
Yeah, sure.
So this is a patient who's having symptoms, right? Shortness of breath on exertion.
Yes,
Yes.
Okay.
with positive
Do we?
exercise test, a stress
Okay.
test.
Right. So the valve area is 0.8 and the stroke volume index is little on the lower side, 35. Ejection fraction is normal. So I guess we need more information. It looks like this is a low flow, low gradient aortic stenosis kind of situation with preserved ejection fraction. So, I mean, there are multiple options, but I'd like to know from the audience, I guess, what they would do before I tell them what I would do.
So after a DSC, the mean gradient increase more than 40. So that goes into a true severe aortic
Oh, I
stenosis.
see. So the patient did have a dobutamine stress echo.
Yes.
Oh, perfect. So that's a true low flow, low gradient aortic stenosis.
Yes.
Then you have confirmed that. Okay, perfect.
Yes.
The BNP was high.
No, we haven't got the BNP on this particular case.
And also sometimes you can add on the CTA
Exactly.
calcium on
Yeah.
the valve.
We
Yeah.
haven't done the CT yet because he's very fit and well, 70-year-old. So his findings clear cut showing that he's got true severe aortic stenosis with sort of compromising his ventricle now.
One
Yeah.
thing, Asif, I would like to add to Dr. To Hafiz's point is that the CTA is still helpful in this situation to decide between TAVI or SAVR. Um, it will give us multiple informations. One is if the patient is going to be suitable for TAVI at all. You can look at the aortic or even surgery at all. Does the patient have a porcelain arch or something that goes against surgery, or something that goes against TAVI.
Yeah, no,
That's
absolutely. That will be the next line of investigation. Absolutely. What I
Yeah.
was saying then in UK we don't necessarily do routinely CT for all our AVR because the resources are a bit limited here. Same goes for some other places, but
the other.
we
I
will be.
understand. The other
So
thing
in
that I'd
our
like to add is that for the low flow, low gradient, the other information you can get from the CT, if you do a valve calcium score, and the valve calcium score is high,
yeah.
usually more than 2,000 for men and 1,200 for women.
Yeah,
That also
yeah,
goes
yeah,
in favor of
yeah.
severe aortic stenosis.
I mean,
I think
just
I
to
think
clarify.
Asif, yeah, just to carry on that point. Uh, Many times, if feasible, we do in our region we do get a CTCA because the patient probably will need surgery. I mean, so patient will need some intervention. When the patient needs surgery, the thing is you need to know about the coronaries anyway. Now, if the CTC clears the coronary, then you can actually avoid doing a coronary angiogram.
Yeah.
So
Yeah, Habib,
CTC is quite helpful.
So Shakil is saying surgery. So we are here to talk about the guidelines and our patient. Like we need
yeah,
to
yeah,
match these two. So in
yeah,
the ESC current guidelines, the
yeah,
cutoff age is 70,
yeah.
but our patient is 67, right?
No,
No,
so
70.
70,
see, this is
70
this is
actually.
also 70 years old.
Patient is 70.
Oh,
What
okay.
so can I just interject because I think the reason for bringing this case is what is the real practice at the moment in UK in generally speaking when a 70-year-old patient comes like that. CT is not routinely done. I personally do because I do minimal access, so I need the CT scan to make a plan, but not routinely CT is done. But then if CT was even done and if it was even a suitable case for a transfemoral TAVI, still the practice in the UK is that this is case
Yeah.
for a surgical AVR. And that's what our current practice still. And that's why to discuss these 2025 guidelines, what Nasrin will tell us, and then we'll take it from there. Hafiz, do
Can
you
I
want to
can
make
I
any
can I
comment
can I
before
can
we
I
proceed?
can I just Asif, can I just
Yeah,
add
sorry.
one
Yeah.
thing? I think the most important thing is from what we have learned in that TAVI world and now moving forward in the other areas of cardiology is the heart team approach. So this is the classic case where the surgeons and cardiologists have to sit together, review all the data, talk to the patient, and make a joint decision what's going to be the next best step. I think that's the most important thing.
Yeah, absolutely, Nasir. And just to say that in our center, in particular in Sheffield, any patient above 70 are discussing the TAVI MDT or heart valve MDT, and then decide which way they goes. And less than 70, they don't. More than 80, they go straight to the TAVI. Between 70 to 80, all cases are discussed. So that's what we practice. But anyway, Hafiz bhai, do you want to add anything before
Yeah,
we
I
proceed?
think also we need to have more info, right? What is the
Exactly.
status of the coronary, other comorbidities, and then
Right.
also the right heart pressure. I don't know, I'm little conservative and old. I still do routinely right heart cath because if it is severe, the article in Jack about the cardiac damage from valvular heart disease, meaning how much is the pulmonary hypertension, whether there is any pulmonary arteriolar hypertension and RV, all these come into play because we don't want to put our surgeons in trouble when there is a big problem of severe pulmonary hypertension, RV dysfunction,
Yes.
and you go to surgery. So we need more info before deciding. And then finally, we also need to talk to the patient because it is ultimately patient-oriented care.
Yeah. Yeah.
Absolutely.
Thank you.
At least we need the angiogram. I definitely agree with that.
Yeah.
My
No.
my
No.
in my center or in our this region practice here, first of all, I think the question's answer is definitely not medical management, right? It's a severe symptomatic aortic stenosis. So the aortic valve need to be replaced. The question is which way, whether you're going to do TAVI or you're going to do AVR, and that will be the topic of discussion. And you know, probably 2 years or maybe 1.5 years back, as Hafiz Bhai said, routinely all cases used to go for predominantly a left and right heart catheterization to sort of help with further decision making. But I'm curious to know how is the practice in many other centers or places where, because nowadays we backed off from routine coronary angiogram if particularly someone is 80 plus and doesn't have significant anginal symptom, which is sometimes difficult to distinguish. But still, if it is not clear-cut anginal symptoms, backed off from coronary angiogram and right heart catheterization as a routine, looking into the CT scan to see whether the proximal segments are clearly visible without significant calcification or not. And if, and then all cases that goes to TAVI, whether they're 80 plus or less than 80, every patient goes to a heart team discussion and then sort of discussed whether patient would need an angiogram or not. Many times we even do not consider angiogram for 80 plus patients. But I'm,
I,
I'm,
I,
I'm
I,
looking
think
forward to
just
see
to add,
what other centers practice looks like.
so I would
just
agree
to
with
add to
Mashrafi.
that,
Our practice was to do routine coronary angiogram for all these aortic valve patients in the past, but we also moved away from that. And like you said, if there's not true anginal symptoms, and if you have a good CT scan, including the coronary CT, we would not. Sometimes we just skip the angiogram.
Yeah,
And
that's
particularly
what
with
we
new,
do as well. Most of the time, what happens in our center, uh, by the time patient comes to the case, they already have an angiogram done. But if they haven't had any angiogram, just do a CTCA. So I would say it's 50-50. 50% of the patients get a CTCA, even young patients, because we need to see the aorta, especially those patients with bicuspid valve, and that gives important information about the type of valve as well. And most of the time with the CT FFR, it's very reliable. If it doesn't show any disease, I personally don't do a coronary angiogram. And almost certainly we don't do right heart catheter in most of the patients, unless it's a very poor Indian lots of other problems. We have moved away from that problem for a long time.
Yeah, just one more thing before we go into the details here. So in our center, we don't do routinely angiogram for TAVI patients anymore over 80-year-old until unless there is a proper symptoms of angina, and then they don't get angiogram. So we do the CT and the echo on the basis of that they get the TAVR, they usually don't get an angiogram until unless there is a other reason to do it. Okay, so Nasrin, do you want to just carry on, please? Yeah, and then we'll have further
Sure.
discussion at the end of the slides. Yeah.
Sure. Okay, before we go through our the guidelines, I would like to do a gentle reminder of our recommendation classes, like class 1, which expresses as is recommended or indicated. Class 2A is expressed as should be considered. Class 2B is may be considered, and class 2, you all know, it's not recommended. And also the level of evidence. Level of evidence A derived from multiple randomized clinical trials or meta-analysis. Level of evidence B generated from large non-randomized studies or single randomized clinical trial. Level of evidence C is opinion of experts. And now here are the recommendations for symptomatic patients with severe AS. Intervention is recommended in symptomatic patient with severe high gradient AS, where mean gradient is more than 40 millimeter of mercury or more. 50 Vmax is 4.0 meter per second. Aortic valve area is less than or equal 1.0 square centimeter or 0.6 centimeters per square meter body surface area, which is a class 1 indication with level B evidence. Its stays remain as like the previous guideline in 2021. And here is a change in the guideline for intervention. Is recommended in symptomatic patient with low flow, low gradient AS with reduced LV ejection fraction, which is less than 50%, irrespective of flow reverse, which was before as with the evidence of flow reverse. And this is the class 1 indication with level B evidence. Intervention should be considered in symptomatic patient with low flow, low gradient AS with normal LVA, more than 50. After careful confirmation that AS is severe. This is a class 2A indication with level of evidence B, which was level of evidence C before in 2021. Here are the recommendations for asymptomatic patients with severe AS. Intervention is recommended in asymptomatic patient with severe AS and LVEF less than 50% without another cause. Class 1 indication with level of B evidence. This is a new recommendation. Intervention should be considered in asymptomatic patient confirmed by a normal exercise test if feasible, with severe high gradient AS and LVEF more than 50% as an alternative to close active surveillance if the procedural risk is low. It is a 2A classification, 2A class indication with level A evidence. Intervention should be considered in asymptomatic patient with severe AS and LVEF 50 or more percent if the procedural risk is low and one of the following parameters is present. Very severe AS or severe valve calcification and Vmax progression is more than 0.3 meter per second. Markedly elevated BNP or anti-pro-BNP levels, which is 3 times more than the age and sex characteristic range. LVEF less than 55% without another cause. It's a 2A class of indication with level B evidence. Intervention should be considered in asymptomatic patient with severe AS and a sustained fall in blood pressure more than 20 millimeter mercury during exercise testing. It's a class 2A indication with level of evidence C. And now the mode of intervention. The new guideline expresses that TAVI is recommended in patients irrespective of surgical risk score 70 or more years of age with tricuspid aortic valve stenosis if the anatomy is suitable. This is a class 1 indication with level A evidence. It was 75 years before in the 2021 guideline. SAVR is recommended in patients less than 70% years of age, 70 years of age if the surgical risk is low. It is a class 1 indication with level B evidence. It was 75, as I mentioned earlier. SAVR or TAVR are recommended for all remaining candidates for an aortic biological heart valve according to heart team assessment. Class 1 indication with level of evidence B. And now we are coming back to the same case, our 70 years old male diabetic patient. And is there any change of your thoughts?
Just wanted to mention because I talked about the heart cath. So the CTA in our area with aortic stenosis diagnosis, majority of the insurance do not pay. So that is another thing to consider about that. What is your payer source and what they allow? It is funny that we are talking the same thing because what we are looking at when we are dealing about aortic stenosis and deciding about what modality of intervention will be ideal for that patient. And basically, we are looking for excluding any other coexistent valve disease, such as MR, and then how is the RV and the TR, and how is the pulmonary condition, any stroke, mini stroke, kidney function, all these in totality. But besides that, I just wanted to point out that the CTA coronaries can be very reliable if it is negative, but if it is calcified, it the specificity actually goes down. So, and many of these patients may have the aortic annular calcification. So I would request you, because I read the CTA, and for my patients, I read the CTA myself, but we have about 20 CTA a day. And it is very important to point out that you need to look at the images yourself and definitely not rely on the radiology read.
Reports, yes.
Yeah, thank you very much, Hafiz. It's a very, very valid point.
True.
CTA is very good for negative, but if there is some disturbance, then it becomes back to the drawing board and do a coronary angiogram. We had multiple patients where we had got CTA saying borderline disease, and we had to do an angiogram to finalize the decision. I want to just the case, as you can see, that this patient, which initially say for coronary angiogram is normal, he's got a tri-leaflet valve, he's got a suitable anatomy on the CT scan for a TAVI, will be candidate as a TAVI as a first preference of treatment. And I would like to pass it to my surgical colleagues now. The first I will ask Shakil Bhai for his opinion, then I'll go to my Bangladeshi consultants here as well. Shakil Bhai, would you think that this 70-year-old
Thank
patient
you.
was absolutely fit and well, and he can go for either surgical AVR or TAVR, and there is no other comorbidities to divide them? Do you think you would argue this patient should have TAVI according to this guideline recommendation?
It's a very interesting case. Presumably, the corner is a normal, everything else is normal. So for a case like this, I think you have to think about your local resources.
ভাই ভলিউমটা একটু
Results.
বাড়ানো যাবে?
Can you hear me? I'm in the plane, that's why I want to.
Yeah, just a bit quiet,
You
so
can
if you
hear me,
can.
right?
Yeah, that's
Am I
better.
right?
Yeah.
Yeah. So what I'm saying is, you have to think about your own area, about your center's results, and about the resources that is available, which Hafiz very clearly pointed out. So in our center, especially you definitely get surgery because we know that this operation can be done almost with 0% mortality. The long-term outcome will be very good, and you have to take into account the finances. So a Taviva costs around 20,000 pounds in UK, as you know. If we use, say, even a Paramount Magnet valve, it's 1,500 pounds. Then you at the hospital, say, 5 days versus 1 day. So, it's a very low risk, very low percentage. I know the European guidelines has changed, but the NICE guideline has not followed that because NICE guideline has to take into account the local resources, the finances, and all this kind of things. So unless the price of the capital is coming down, I think it will be hard to justify to logically enroll it within the NHS. That's my point number one. Second point is this patient presumably has more than 10 years of life expectancy. So you have to think what's going to happen in future if the capital fails. I know the valve failure chance is low with the new resilient component in it, but future coronary intervention and valve intervention will be complicated in this patient. So, in my view, this is a patient who should have surgery because it can be done with almost 0% mortality and really with very good outcome and very good long-term results. I mean, obviously, if the calcium score is more, if the coronary height is less than 10 millimeters, if it was a type 1 bicuspid, things would have swayed even more on the direction of surgery. At the end of the day, it's a hard thing he has to decide, and it's the patient's choice as well. We have to take into account all these things.
Thank you very much, Shakil bhai. Hafiz bhai, I'm going to get back to you. I have seen all your comments. I'm just going to get back to you. I just want from one of my Bangladeshi consultants' point of view. Shuman bhai, are you? Can you hear me? Shuman bhai, just wondering if you can give us a perspective from Bangladesh. This group of patients, how would you try to treat them? Okay, all right. Prashanta, what's your experience in Bangladesh perspective this one?
Actually, from this point of view, 70 years old male, no other comorbidities. At this moment, our current practice is, as you know, we are not getting any insurance help. So patient has to pay from his own pocket. So we, otherwise fit patient, we go for the surgical AVR. But basically at this moment, at this age, if there is comorbidities like CKD or history of CBD or something like that, we go for TAVR. But at present, we have two devices only, Meril from India, which is costing around 20 lakhs Bangladeshi taka, and we have second, which is around 33 lakhs in Bangladeshi taka. So this is also put ourselves to think about the practice. So at 70 years old, this patient, we go for the surgical ABM.
Thank you very much, Prashanta. I don't know, is Shuman bhai, Nazmul Hussain Shuman bhai, is he? Okay, all right. Okay, so
yeah, Asif, yes, I'm here.
Oh, Shuman bhai, thank you very much. Okay.
Yeah. Prashantada has mentioned the scenario here, but he works for one of the corporate hospitals. But in their real life scenario in Bangladesh, as you know, it is often dictated by factors other than the clinical issues, the socioeconomic issues, and on many occasions, in particular, is this patient, a 70-year-old patient, and the other things as I've described. Maybe in many cases they'll follow just the second option. They'll follow up for further deterioration, which is a common practice. And we don't. These patients are not referred to surgeon's events because as they are managed by cardiologists, some of them will prefer keeping them for a little longer. So in Bangladesh, as I mentioned, that there are other issues get involved as well.
Thank you very much, Shuman bhai.
But if there is options, I think again because of the economic issue, the surgical aortic valve replacement would be the preferred choice in majority of the cases.
Yeah, that's really helpful. What do I?
I'm in trouble because my net is so unstable, so I have to go back to my mobile and talk from there.
No problem.
The point is, you have to do something about this patient. Now, if he can afford it, that is, of course, very good. As uh, Hafiz Bhai is commenting, the patient can have breakfast on his bed on his own the next day. That you cannot think of in a aortic valve replacement, surgical replacement patient. But what is the scenario in my country? The highest number of valve replacement in this country is done at NICVT. Do you know why? Because we provide most of these patients get free valve. That's why. There are so many patients, but we do around 300 aortic valve surgeries, aortic and mitral valve 300. This year, this will be much more because we have been able to acquire more free valves from the government. So the demand is there, but the affordability issue is something that dictates what you can do. And as Shuman was saying, many a time the patients are also reluctant in our country to go for the surgery. And it's imperative on the doctor's part, in the cardiologist's part, they should decide not to delay too much. Sometimes you are saying that please, in the next 6 months, perhaps you would have to go for surgery. Patient will come back after 2 years. আমি তো ভালো ছিলাম এই জন্য আসি নাই কিন্তু then we find out that already the lesion has progressed so much, the LV has deteriorated so much, the operation has become treacherous. Operation has become treacherous. That's the problem we face. Shuman was rightly saying there are many factors beside the clinical issues that dictates which patients are going for which surgery. Nowadays, we are doing the TAVI in here, and many people can actually afford it. Those who can actually afford it were not doing it. Now they are coming forward and asking for, can we do it? Because they are seeing the results. Hopefully, TAVI will get much more traction in future, and the surgical replacement will be always there. And we have a very good track record. Our surgeons are doing a great job of doing it regularly and quite well. The outcome was quite good. So hopefully, with the government support, it will be prospered much more.
Yeah. Thank you very much, Wajid bhai. We got a very
Yes, my friend.
yeah, thank you. I think in Bangladesh, this is also another important aspect to consider. It's not only the guidelines, patients' affordability, and patients coming in the right time to have the right treatment. Uh, and one question to my cardiology colleagues who does TAVI, so Hafiz bhai, Marshal bhai, Nasir bhai, is that just tell me one thing. So we are all very fussed about this patient waking up, going home next day or the day after, having breakfast or getting married, all fine. Can you have a look at the broad picture on a 70-year-old patient who's doing a TAVI? How do you know in the long run that is going to give you the best possible outcome? Whereas you know that if you do minimal access AVIA, they can go home. Most of my patients in generally go home day 4, day 5, and they hardly have any problem after 6 weeks or so. So we're talking about the first 6 weeks and the rest of their life. Which one is actually broader? So Hafiz bhai.
Actually, can I, before Hafiz Bhai goes, can I just answer
Oh,
that
Nasir bhai,
particular
yes, please.
question?
Yeah.
Yes, because you have asked a great question. I had exactly a same patient just last week. So your guideline is very similar to the SCC guideline. The only difference is the age cutoff is 65. So below 65, surgical valve is preferred. Above 80, TAVI is preferred. 65 to 80, we always have a discussion, shared decision with the patient. Now, I had a patient very similar to this just a week ago. He's 66. He had this low flow, low gradient. He's getting short of breath and exertion. I take him to the cath lab. His EF is like 40 to 45%. In the beginning, I wasn't too sure if I would do it. In the cath lab, I put a catheter. His coronaries. I take a picture of the coronaries. His cardiac index is 1.5. I start dobutamine. The resting gradient is 19.5. With 20 of dobutamine, the gradient goes up to 53. So aortic stenosis is confirmed. And there was an RCA lesion. I fix it, and I then send him to the surgeon for their opinion. The surgeon tells him, yes, if you have a TAVI, we don't know the longevity. it can go down in 10 to 15 years. So you'll have to have a second surgery. So why don't you have an open heart now, have a bioprosthetic valve, and then that's in 10 to 15 years from now, you can have a TAVI. So the same day, the patient and his wife comes to me, and they said, to us, the immediate recovery is more important. So we want a TAVI because the wife was telling me, I know my husband, he will not go through this 3 week of recovery of the surgery. He's too impatient. Plus, he has left shoulder pain. He wants to have the shoulder surgery as soon as possible. So TAVI is my choice. I call the surgeon, put him on the phone. We make a joint decision. For this patient, we're going with TAVI. So this is exactly what we need to do. It's a case by case, the joint decision. It's whatever is best interest for this patient. That's all. Before Hafiz Bhai goes. Hafiz Bhai.
Yeah, absolutely brilliant. Excellent discussion. And I just wanted to point out that on the TCT, Michael Mack, actually, he was the president of the American Society of Thoracic Surgeons. He was the PI on the Partner 3. He presented this. And 7 year on, in the low risk group, Partner 3, the TAVR valves was non-inferior to SAVR. So we have data now coming along, and it is pretty neck and neck. I'm not saying that TAVR performed better, but I'm saying that it was neck and neck in comparison with surgically placed aortic valve. So, but I think it a lot of things come into play. We can talk and look at the data, but I think it is unique for individual patient, unique for the center, and unique for the family, and a lot of comorbidities, and what is the goal of care. All these come into play. So it is a complex situation, but I think it is good that we are talking together to sort this out. And that case that you brought up is excellent. I just wanted to tell you one small thing. If you look at the unload TAVR, these borderline cases where there is moderate, maybe moderate to severe AS, but there is symptoms and heart failure, I don't think we don't need to go extra length to prove with the dobutamine. I think we are there already.
Thank you very much, Hafiz Bhai. Shakil Bhai.
I just quickly make a point. Great discussion. I agree with everything.
Shakil Bhai, can you speak out a bit louder, please? Yeah.
Yeah, I think the only issue I have, I agree with everything you guys have said. The only thing, the issue is putting a blanket age cutoff.
Yes.
Sometimes can be misinterpreted by a lot of people. I mean, not everyone is Hafiz Bhai, Nasser Bhai, People will just think, oh, this is a 71-year-old.
I'll do TAVI.
So it does say that, like, all of the trials, partner 1, 2, 3, whatever trial you say, they are selected group of patients. And in a patient with a tricuspid valve, less calcium, then, no coronary disease, not low-lying coronary, the result will always be good. But the worry is these data will be misinterpreted by lots of people around the world. And that's what we are seeing. I have, obviously from Bangladesh, we have close connections. And we do see from time to time 68-year-old, 70-year-old being considered for TAVI who have a type 0 bicuspid, true bicuspid valve with a severe complication, and both coronaries coming from the single sinus. So those patients, if you put a TAVI there, it's going to have paravalvularly annular rupture, and most importantly, coronary occlusion. This is the worry with this blanket age kind of.
Thank you very much. Prashantada.
One question here, Asif, just out of curiosity, not clinical question. We discussed about the Bangladesh situation, but I have a question. This question is for Hafiz Bhai and Nasser. We know that a substantial percent, well, it's like 10% of US population do not have insurance coverage. Then the other day I was listening to Bernie Sanders, who was speaking that with 20 million people added to this. What happens to these people? I just wanted to know in such scenario.
So So, Shuman Bhai, the good thing about U.S. health system is anybody above 65 has the government insurance, the Medicare. So it's a socialistic model. Although America is a capitalist country, but anybody above 65 has the Medicare. So the Medicare will cover for TAVI. The challenge becomes the question you asked. Challenge becomes is anybody is below 65, but the chances that person will have a a surgery becomes a challenge, but many of them can apply through get like Medicare, which is there are certain programs through the state and sometimes through the federal government they can get. And also now there is Obama started a thing called the marketplace. You can go and buy insurance. So those are the options. But if they have no insurance, then like you said, then that becomes a huge challenge here as well.
আমি একটু বাংলায় বলি, আমেরিকা হচ্ছে মাফিয়া স্টেট। তো বলে রাখবে এগুলো করবে, বলে খাতায় লিখে রাখ, পরে দেবো। আর চায়না থেকে বড় করবে।
এই প্রোগ্রাম কিন্তু রেকর্ড এন্ড লাইভ হচ্ছে হাফিজ ভাই। হ্যাঁ,
সো ওই মেডিকেয়ার মেডিকেড ওগুলোর পেমেন্ট অনেক কম, কিন্তু আসলে যেটা হয় যে সুমন ভাই, ইভেনচুয়ালি যখন কেউ একজন লাইফ থ্রেটনিং সিরিয়াস কন্ডিশনে আসে না, তো ওগুলো কিক ইন করে। আর ওই যে হাফিজ ভাই বললেন যে এগুলো খাতায় লেখা থাকে, হাসপাতাল মানে ওগুলো চেষ্টা করে ওটার মানি রিকভার করার জন্য, কিন্তু আসলে চিকিৎসা বেশিরভাগ সময় থেমে থাকে না, চলতে থাকে আর কি। মানে হাসপাতালকে অনেক সময় প্রচুর কস্ট অ্যাবজর্ব করে নিতে হয়। এই কারণে হয়তো এদেশের আপনার কস্টিংটাও বেশি, এই অন্যান্য অনেক কস্ট অ্যাবজর্ব করার জন্য। কারণ ওই যে এখানে রুলটা হচ্ছে যে everyone should be treated in a life threatening situation, you cannot refuse anything. তো ওই প্রবলেম
কস্ট একটা কিন্তু খুব ইম্পর্টেন্ট ইস্যু। এই নাইস গাইডলাইনে যখন পড়ে ওরা কস্টটা দেখে। ট্যাভি ভালভের বিগেস্ট প্রবলেম ইউকেতে একদম ব্ল্যাঙ্কেটলি এনরোল করার জন্য হচ্ছে যে এটা দাম £20,000। হ্যাঁ, আমি যে রিজনে থাকি ডেমিশনারে অনেক এলডারলি পপুলেশন, এখন যদি সবার জন্য ট্যাভি ওপেন করা হয় 70+ guideline, that will huge impact on the NHS. So, I mean, these are some practical points. Whilst I agree with the principle, straightforward tricuspid valve should have very good results for 7 years. You can problem now high resilient tissue. There's no reason why long-term result are follow right? If you think logically, that is one of the problems. যেটা বাংলাদেশের মতো দেশে একটা প্রবলেম। বাংলাদেশে আমার বিগেস্ট প্রবলেম যেটা মনে হচ্ছে, ট্যাভি এত ইনফ্রিকুয়েন্টলি হয় এবং কমপ্লিকেশন হলে most of the patients don't know how to deal with it. Having dealt with some of these problems, we know maybe ওয়াজিদ ভাই প্রশান্ত দা ওনারা আরো এলাবোরেট করতে পারবে এই ব্যাপারে। বাট কস্ট যদি না কমে আসে, it is going to be a real problem.
I wanted to say one comment because like us, the hospital administrators, they have their journals, and they liked our publications when we looked at the TAVR done as an inpatient versus outpatient. The outcomes were bad in the inpatients. Right. So they took on that, and they really advised that we as operators do not do inpatient TAVR, stabilize and send home. The problem we have, and Mashrafi, you probably will appreciate that we don't get those patients back. Some of them just get lost. So this is a very big problem in the US. When we have the problem of finances and insurance issues here also. It is a tough situation.
True. This is something that came out in last probably a year, where inpatient or urgent TAVRs are very, very discouraged. And that's true because the data shows that the overall outcome, mortality, everything is high. TAVR cannot be like a salvage procedure probably. TAVR should be like a more in a controlled situation. A patient is 70-year-old.
Mashrafi, can I ask you something? If someone critical aortic stenosis presents with heart failure, to the hospital, you're saying that that patient is not going to have inpatient cover because the hospital manager is saying that the result will be bad.
Yes, we
I
have
think that's
data on that.
worrying, isn't it? That's very that's a dangerous factor.
So it is
But yeah,
not that blatant, Shakil. They will not tell you not to do. They will tell you always whatever you think best for the patient, but they will look at the data at the end of the year and saying that why, and they will show you their argument that these are the bad outcomes. Can we look into this? Which is basically telling you indirectly that try not to do it. And also when we did,
You do it, isn't it?
yeah, I mean, if there is no other
sometimes we do.
bailout, because I tell
Sometimes we
you one thing, if it is a critical age decompensated and we are not getting better and patient has borderline or no insurance, I actually want to do it now rather than leave it because I have a license too, and also we are dealing with a patient. I mean, it is obvious, right? So
Right, like sometimes we put patients on even ECMO or
yeah,
tandem heart to do it, right? So it's sometimes done, but most of the time we sort of try to, stabilize the patient from a decompensated state to a compensated state, and if possible, would like to do as an outpatient rather than an inpatient, because so far the data also showed that the inpatient salvage ones is outcomes are bad. So I can try
Yeah,
to put those.
Masha, right. Yeah. No, the point is that that data will be biased because you are doing on those very high risk patients where your hand
True,
is
no
tied
doubt about
and you
that.
are
No,
doing those cases, so the risk
Yeah.
of mortality will be high. But in our surgical practice, a patient with critical aortic stenosis comes with heart failure, pulmonary edema, is not going to go home without an intervention, whether it is surgery or TAVI. And that's what we're still practicing in UK. So we don't have that restriction about doing not doing TAVI in house. I think Shakilbhai, you will be agreeing with
I
in
think,
fact.
yeah, I think it's inappropriate to send that patient home, like without sorting the problem out, because otherwise you're cherry picking the cases. Like patient is sick, heart failure, control the patient, and then send the patient home without dealing with the mechanical problem, which is
it
what
is
you're doing.
absolutely cherry
Completely
picking,
different.
Shakil. It
Yeah,
is absolutely cherry picking. And
yeah.
when we talk about surgery versus anything cardiology, I admit we, the cardiologist, we cherry pick a lot and we give you all the bad ones.
one thing I completely go against, which is like someone sometimes they say, "Oh, can you just do a BAV at this point?" No, I
Yeah.
don't do
No,
it.
no, no, no.
Not
Not,
If you
I
works.
do,
don't.
if you are in there, you should just do a TAVI. Yeah.
Right.
Yeah,
Sorry to
yeah.
interrupt, guys. Prashantoda had a question, and I think he had his hands up a long time ago. Dr. Prashanto, do you want to ask your questions or your comments, please?
Actually, Hafiz Bhai was telling about right heart catheter. Actually, in our context, we have a very neglected old cases in our practice, especially in NICBD or heart foundational scenario, where we have to go for the right heart catheter. Hafiz Bhai.
Oh, so you know that I'm old, so I like right heart. But another reason I like heart because we need to train our fellows. And the third reason is that sometimes RV assessment by the echo may not be optimal because you are cutting off Doppler does not lie, but you may not get the full picture of the tricuspid triggers and velocity derived pressures. And there may be comorbidities such as lung disease. So you really need to know transpulmonary gradient and who is contributing what. So I will agree that we probably don't need a routine writer, but if you have any scope, it takes another 3-4 minutes to do the writer. It gives you a lot of information. So I'm for it, but if you don't do it, I'm still with you. But please look at the echo and have a good feel about the right side. Because if RV goes down, whole cardiology goes down.
No, everybody goes down. Hafiz bhai, even we dread RV failure. That's my most dreadest thing when I do an open heart surgery. Um, okay, so I think one thing we can all come to an agreement: this patient needs an intervention, and there are options of doing TAVI. But this is what we were trying to highlight in this discussion in a broader spectrum, that should these young patients should have a TAVI and then a second stage TAVI again, or they should have a surgical AVR and fix it in one go? Are we trying to achieve a better outcome with a some time for recovery, or we are trying to achieve a quicker recovery and maybe not as good as outcome with the surgery? So I think time will tell us which way will be applicable for these patients. We still, our practice is that this group of patients should be discussing the heart team MDT. I think that should be the take-home message. What we practice in UK, we practice in USA. That should be the take home, that all these patients should be discussing the heart team meeting and then make a final decision. Before I conclude the session, I just want to go through all my panelists to have their last comment. So, Hafiz bhai, do you want to start, please?
No, I have talked a lot. I'm good.
Okay, Hafiz bhai realized now he's been recorded. Okay, I'll go to Nasir bhai.
No, thank you so much. I mean, this was excellent discussion. Like I said, it's very practical problems, and like you said, it's on the end of the day, it's a heart team, coming together and making whatever is best for the patient. Thank you.
That's very kind. Thank you, Mashu bhai.
So for this patient, either by CT or angio, if there is significant coronary artery disease, I think in my center, this will go to you guys for an AVR cabbage. If there is nothing like that, it's only AVR that's a patient needed, then it will come to this heart team meeting. And if anatomy and everything is visible, then what we usually do here in the heart team meeting, we try to send a combined message through our, to our patients. If we feel like the surgery should be better, we tell them surgery is better. If there is a nodule, right? If there are multiple annular nodule, we will say that, there will be leak, you better go for surgery. If the patient is 70, right? But if the anatomy is good, and then it's both way, right? And if I give this choice to 70-year-old any man that, hey, you have equal outcome chance, I know 99% of them will go for TAVR. So there we go. That's why the TAVR is probably getting more and more high number of procedures, because if everyone wants to go for less invasive way. And you guys, you were saying about this minimal or like a smaller surgical approaches, but many center doesn't do it. Like my center, they still do conventional open heart surgery for even simple AVR. So that's always a concern for the patient.
Thank you very much.
Asif, I would like to add just one more thing.
Yes, please.
I think one basic difference in the practice between US and UK is that the surgeons are always scrubbed in for a TAVI case, but I don't think that's required in UK. So in USA, So in USA, it's a TAVI is our case. It's not surgery versus cardiology. I think that's something you need to bring into United Kingdom. Maybe talk to the people up there and start doing that.
And equally paid. That's more important.
Exactly. It's split. The fee is equally split between us. Yes.
Yeah. No, we are all NHS-based salaries, so our fees doesn't matter at all. Yeah. So it's all same for us.
And we let the surgeons to cross the valve, do something.
Yeah. Thank you very much, Hafiz bhai. Wadud bhai, do you want to have any comments, please?
আসলে এই যে পেশেন্টটা, এটা একটা খুব গুড কেস ফর ট্যাফি। তুমি যেটা বলছিলে যে পেশেন্টকে যদি অফার দেওয়া হয় যে অলমোস্ট ইকুয়াল আউটকাম, অলমোস্ট 100%ই আসলে ট্যাফির পক্ষে যাবে। আমাদের দেশে ফাইন্যান্স একটা বড় ফ্যাক্টর হয়ে দাঁড়িয়েছে, কিন্তু তারপরেও যেটা দেখি আমি যে অসংখ্য পেশেন্ট যারা আসলে এফোর্ড করতে পারত, তারা কিন্তু জানতো না বা করতো না। এখন কিন্তু আস্তে আস্তে কিন্তু ট্যাফি আমাদের দেশে জনপ্রিয় হওয়া শুরু হয়েছে। এন্ড হোপফুলি যে আমাদের যে ইন্ডিয়ান ভাল্বটা যে ইউজ করি আমরা, মাই ভাল্ব, আমরা এটা যদি পারফরমেন্স এরকম ভালো হয়, তাহলে খরচটা কিন্তু মানে একটা গ্রহণযোগ্য পর্যায়ে চলে আসবে। এই ফাইন্যান্সটা আমাদের জন্য বড় সমস্যা হয়ে দাঁড়িয়েছে। আমাদের নাম্বার অফ কেস কম দেখে যে কার্ডিওলজিস্ট বা কার্ডিও সার্জন যারা এটাতে প্রফিসিয়েন্সি অর্জন করবেন, সেটা খুব ডিফিকাল্ট হয়ে গেছে। এখনো কিন্তু আমাদের সেই বেশিরভাগ সময় বাইরে থেকে একটা টিম আসেন, আমাদের দেশি টিম তাদের সাথে মিলে কাজ করে। একদম এককভাবে ইন্ডিভিজুয়ালি আমাদের দেশের টিম দাবি করেছেন তা কিন্তু এখনো হয়নি। তার মূল কারণ হলো নাম্বার অফ পেশেন্টস। কিন্তু যেটা লক্ষণ দেখতে পাচ্ছি হবে, মানে এখন দেখি যে অনেকেই ইন্টারেস্টেড এটা করার জন্য। একজন খুব নামকরা হ্যাপাটোলজিস্টের কথা বলি, উনি না মায়েরটা করিয়েছেন, ইন্ডিয়া থেকে করেছিলেন। আমাকে বলল, বাদু আমার মাকে এটা করার পর আমার মনে হলো আমরা কেন এটা এতদিন করি নাই, আমরা তো এফোর্ড করতে পারতাম, আমরা তো আসলে ধারণা ছিল না। এখন তো আমি নিজে সবাইকে বলে বেড়াচ্ছি, আমি হ্যাপাটোলজিস্ট, যে ভাই তোমার মা বাবার এটা থাকলে তোমার সামর্থ্য আছে, জলদি করে এটা করাই নিয়ে আসো। এই জিনিসটা হয়ে আসছে। আর দ্বিতীয় কথা বলি, আমার দেশে আসলে সার্জিক্যাল রিপ্লেসমেন্টটা সবচেয়ে বেশি প্র্যাকটিক্যাল, এবং সেখানে মেকানিক্যাল ভাবটা আরো বেশি প্র্যাকটিক্যাল। কারণ আমি যেটা দেখি যে আমরা যে টিস্যু ভাব যেগুলো করে, সেটা 10 বছরের মাথায় সিগনিফিকেন্ট গ্রেডিয়েন্ট তৈরি হয়ে যায়, এবং ভাব লিকেজ দেখি আমরা। তার মানে রুগীর বয়স আমাদের দেশে তো বেশিরভাগ যেহেতু রিমেটিক অরিজিন, তাদেরকে 30-40s এর মধ্যে তাদেরকে ভালভ রিপ্লেস করতে হচ্ছে। বাই 50s-60s তাদের যদি আবারও রিপ্লেসমেন্ট করতে হয়, that becomes very very difficult for everybody, for the surgeons to do the redo surgery, for the patients to do the surgery and afford it. All these things become very difficult. তো সেক্ষেত্রে যেমন সেদিন আমাদের এখানে যেমন একটা পেশেন্ট এরকম হয়েছে যে ভালভিন ভালভ সার্জারি হয়েছে, যে টিস্যু ভালভ ছিল বলে করতে পেরেছে, টাভি করতে পেরেছে। তো এই জিনিসগুলো মাল্টিপল ফ্যাক্টরস গুলো কাজ করে। অ্যানেস্থেসিতে হাইয়েস্ট নাম্বার হয় কারণ অ্যানেস্থেসিতে আমরা ফি দিতে পারছি। প্রাইভেট সেন্টার গুলো তুলনামূলকভাবে ভালভ সার্জারি অনেক কম হয়, বাইপাস কিন্তু হর হামেশা হচ্ছে, সে তুলনায় অনেক কম হয় বিকজ অফ দিস ফ্যাক্টরস। যাদের হয় এই ভালভ ডিজিজ গুলো, তাদের বেশিরভাগই হলো যে মধ্যবিত্ত নিম্নবিত্ত। আর এল্ডারলি পপুলেশনে এই যে অ্যাথেরোস্ক্লেরোটিক না হয়ে স্ক্লেরোটিক যে ভালভগুলো আছে, সেরকম পেশেন্ট কিন্তু আমরা পাচ্ছি। কিন্তু এখনো আমাদের দেশে কার্ডিওলজিস্টরা খুব রিলাক্টেন্ট টু সেন্ড দিস পেশেন্ট ফর ভালভ রিপ্লেসমেন্ট, যে বয়স হয়ে গেছে এখন করে কি করবে। তো টাভি যখন এসছে তখন কিন্তু এটা অনেকে আস্তে আস্তে মত চেঞ্জ করছেন। হোপফুলি আমরা নাম্বারটা অনেক বেশি দেখতে পাবো সামনে। আজকের ডিসকাশনটা সবচেয়ে ভালো জিনিস ছিল যে সার্জন এবং কার্ডিওলজিস্ট দুই পক্ষই খুব ওপেনলি প্র্যাকটিক্যাল কথাবার্তাগুলো বললেন, কি করা উচিত কি না, ফাইন্যান্স কিভাবে ইনভলভ করে আমাদের ডিসিশনকে ইনফ্লুয়েন্স করে কিভাবে ডিসিশনকে, এবং পেশেন্ট চয়েস যেটা, সেটা কিন্তু এক্সকিউট হতে পারে যে মিডিয়া কি বলছে সেটা শুনে। মিডিয়া তো টাভির পক্ষে বিরাট জোর গলায় কথা বলে বেড়াচ্ছে, এবং পেশেন্টটা কিন্তু না বুঝেই অনেক সময় সেটার পক্ষে চলে যাচ্ছে। যে এআরটি রিগার্ডেশন বলছে যে না আমাকে এটা করে দিতে হবে, যে বলছি যে ভাই তোমার রেজাল্ট ভালো হবে না এবং এটা করা সম্ভব না, বিশ্বাস করতে রাজি না। তো সবকিছুই সময়ের সাথে আরো চেঞ্জ হবে সেটাই আশা করি। থ্যাংক ইউ এভরিওয়ান।
Well, right, thank you so much. It's a very good point that patient gets biased by not being properly educated or not properly being informed, and that's where the role plays by our doctors. Inshallah, it will be very well. This information needs to be circulated properly so that patient can also make the proper decision. This time I need to go back to my surgical colleagues before ending, so I'll start with Shuman Bhai.
Thank you, Asif.
Yeah.
It was a very good discussion. খুব ভালো discussion হলো, interesting. আমার perspective থেকে actually I have all my professional life I have worked in public hospitals and private cases in small setups. So those patients, always there was an economic issue, and they would have preferred mechanical valve in any case. Even that patient was in 70s. Very rarely I have used tissue valve. The second issue is these patients are often referred to us quite late. We get the aortic valve patients in severely calcified conditions, in very bad shape. That is just what I said, that often the cardiologist thinks a patient care পাঠিয়ে কি হবে অথবা আরেকটু দেরি করাই, এই টেন্ডেন্সিটা কাজ করে। And we forget that without intervention, severe aortic stenosis is a deadly disease with 5-year survival rate less than most of the common malignancies. So this is one factor we tend to forget. Anyway, so and the last thing which I often say these days, not only as a surgeon but as a director general, that we in Bangladesh, we have to do medical research. All the data we use, these are Western data, Western guidelines, which might not be applicable for our population, not only in the cardiac surgery, in many cases. So there should be more research work in Bangladesh to set up our own guidelines, our own standards. Just for and this is true for all the branches of medical science. So these are the three points I'd like to add, and thank you for the discussion.
Thank you very much, Suman bhai. Thanks for joining. Prashant Dada.
Oh, thank you and congratulations, PHA, for a nice time demanding topic. And congratulations, Nasrin. We are waiting to get much more information from you. Really waiting.
Definitely.
বাট আমার যেটা মনে হয় একটা পার্সপেক্টিভ, বাংলাদেশের আমাদের দুইজন লিডার আজকে উপস্থিত ছিল, প্রফেসর আব্দুল ওয়াদুদ চৌধুরী এবং প্রফেসর নাজমুল হোসেন সুমন। আমি মনে করি যে আমাদের কয়েকটা জায়গা খুব দেখা দরকার। একটা হলো আমরা আরো হার্ট টিম ইনভলভমেন্টটা বাড়াতে পারি। আমি মনে করি এটার সুযোগ আছে। আমরা সবসময় এনলাইটেড হচ্ছে আপনাদের দ্বারা, পিএইচ এর দ্বারা, কিন্তু এটা মানে ক্লিনিক্যাল প্র্যাকটিসে এটার ব্যবহার কম হচ্ছে। এক, দুই নাম্বার আরেকটা জিনিস আমার যেটা মনে হয় যে, যেটা প্রফেসর উদ্দুত রেইজ, টিস্যু ভালভ ফেইলিউর। আমার মনে হয় যেহেতু আমরা ছোট সাইজের ভালভ লাগায় অভ্যস্ত, 19 or 21, we should try to put larger sizes valve where real gradient and the initial implantation time will be low, and then the valve may last longer than expected at this moment. ফারুক স্যার থাকলে আরো ভালো হতো, কারণ স্যারেরও এই বিশ্বাসটা আছে যে 10 বছরের নিচে বায়োপ্রসেসেস গুলি ফেল করছে, ইভেন যেগুলো লিডিং ভালভ ইন দ্য ওয়ার্ল্ড। আর আরেকটা জিনিস হলো টেবারের প্রতি আমাদের যে এটাও প্রয়োজন অনুযায়ী বারবার দিনের পর দিন তৈরি হচ্ছে। এবং অদূত যেটা বলছে যে অনেক রুগী আমরা এখন দেখি যে আমরা 10 বছর আগে যদি তাকে টেবারে অফার করতাম, সে তার কোয়ালিটি অফ লাইফ অনেক ইমপ্রুভ করতো। উইথ দিস, থ্যাংক ইউ অ্যারেঞ্জিং দিস ওয়ান, আসিফ। Waiting to see you in the next month. Thank you.
Okay, thank you very much, Prashant Dada. Shakil bhai, do you want to conclude?
I thank you very much, Asif. Really good webinar, lots of discussion. I think everyone has said what I wanted to say. Basically, whatever modality it is, whether it's heavy or a surgical valve, you need to make sure that the patient gets a good tissue valve. If you're using a tissue valve, I see in Bangladesh lots of the time the free tissue valves are very low quality ones. Maybe I will be able to confirm that. That's why they say that. Second thing is, you look for small valving. That is the most important thing. If you have a radial valve replacement of 25-30, then that valve is not going to last long. Third thing is, do on daily TOE, make sure there's no paragraph building. And most important thing is, think about the lifetime management of the patient. So when a patient comes, you need to have this discussion. How and what is the lifetime management of that patient? This should be done by a heart team. Means that in Bangladesh, there is no heart team. There are very scattered heart team here and there, but there is no proper heart team. We see that in coronary artery disease as well. So thank you everyone for your time.
Thank you very much, Shakil bhai, joining from Sky. Thank you. But it's important thing. So that's the take-home message for us. And Nasrin, thank you very much for doing the presentation. I hope you have a good time in Papot as well. Not as good as Sheffield, I presume, but you know what you can do. But excellent time, everybody. Thank you very much for joining, and hopefully, inshallah, we'll see you soon with our next session. And there is a Aortic program organizing in Bangladesh by PHA. So Shakil bhai, thank you very much for all that, and hopefully we will update the whole team about that very soon.
And Asif, thank you, because you moderated excellent.
Thank you, Hafiz bhai. Thanks for joining. Everybody take care. Inshallah, see you again. Bye.
Thank you. Thank you, Nas.